A warm welcome to today's talk, Tuesday the 2nd of March. Now, I've been whinging for a few days about the lack of data from the real-world surveillance of the Oxford Astrazeneca vaccine. We know the Pfizer's looking pretty good. Well, the data's come through now on the Oxford Astrazeneca vaccine. And to give you the bottom line on this, it's absolutely excellent. We've got protection of 80% or more from both vaccines against hospitalisations and deaths after one dose. And we know that immunity gets even better after 2 doses. Remarkably important video for the United Kingdom and the United States today. Let me tell you why. So most of the results from this study for both for the Pfizer vaccine and the Oxford AstraZeneca vaccine. Now, I know the Oxford's not being given out in the States yet. It will be eventually. But we think it will. The trials are going to wrap up there. We're hoping this month, in fact. So we know it's going to come in both. But the point is the efficacy is good for both for the Pfizer. Now, this doesn't comment on the Moderna, so that doesn't help us for the States, but the Pfizer it does. And the good news is that the efficacy is high against the UK variant, the B117 or the 2012 or the Kent variant, whatever you want to call it. So the Pfizer vaccine is working against that in preventing hospitalisations and deaths, and the Oxford vaccine is working against that. So good news for everyone, really. Published on the government website here. So this is the Public Health England website. So this is basically, well, you can't say it's fully accepted yet. It has to be peer reviewed, but it's on the government website, and it's good quality surveillance data. So let's get straight down to it. So this is the government site here. Check it out. Just clicking it will take you straight through to it. Early effectiveness on COVID-19 vaccine with the Pfizer vaccine, the mRNA vaccine, and the Oxford vaccine. So that stands for chimpanzee, ChAd, adeno, Oxford, and it's their first coronavirus vaccine. So when they do one for the new variants later in the year, it'll probably be called 2. So chimpanzee, adenovirus, Oxford 1. Adenovirus vector vaccine on symptomatic disease. So this is about symptomatic disease, preventing people becoming symptomatic, hospitalisations and deaths in older adults in the UK, and a test negative case control study. And I'll tell you what a case negative test or a test negative case control study is in a minute. It's nothing complicated, actually, but it fits in better in a minute. This is the preprint study. We look forward to the peer-reviewed data, of course. As always, I've read it and it looks good to me, and it is good because otherwise the government would have published it on their site. So in a sense, it's been partly peer-reviewed by the Public Health England officials already, really. But we do need a full academic peer review. But I'm sure none of this main data is going to change. So real-world effectiveness of the Pfizer BioNTech vaccine, that's that one, BioNTech vaccine, and the Astrazeneca chimpanzee adenovirus Oxford vaccine against confirmed COVID-19 hospitalisations and deaths and infections. Because this is probably what we really want to know about. And as I've already said, the news is good. We'll see how good in a minute. To estimate effectiveness on the UK variant of concern is another outcome. And again, as we've already said, it is efficacious against the UK variant of concern. Tells us nothing about the Brazilian, tells us nothing about the South African. It only tells us what it tells us, obviously. Now, setting this community PCR testing in England. So this is English data. We have had Scottish data, which was fairly similar. Much larger population in England, of course, so useful to know. 8th of December, the data was collected between the 8th of December and the 19th of February. Now, this is important, so I've just put this graph in to remind us. So that's the 18th of December there. So it's kind of from that kind of time period there through to the 19th of February, which is, not long ago really, is it, to about there. So it's covering this huge spike in cases that we had in the UK. And we know that this increase was mostly due to the new variant. So we know this is new variant stuff, and we'll give further evidence for that in a minute. So lots of infections around at that time. So because there was lots of infections around, lots of opportunity for people to get infected. So in a sense, this is a great extension of the phase 3 clinical trial. but as we'll see, larger numbers. All adults in England over the age of 70 were eligible to take part, 7.5 million. They didn't all take part because they didn't all become symptomatic. But all symptomatic COVID-19 testing in the community in over 70. So basically everyone who was tested over the age of 70 for symptomatic COVID-19 during this time period went into the study. Nearly all of them, as we'll see. Tested negative control design. Now, what this means is, if people tested positive, then they essentially went into the experimental group. If people tested negative, they went into the control group. So let me just show you what I mean in real numbers, because what you basically got is a huge, large-scale, ready-made clinical trial here. So in that age group, in the over 70s, between those two dates, 174,000 PCR community-based tests were conducted in England. 156,000 of those, 90%, were linked to vaccination data. So basically, that's the number in the study. Because with that 156,930 people, they were able to link the result of their PCR test with their vaccination status. So this is basically testing everyone now. Now, 44,000 of those tests were positive, 28.4. Of those coming forward with symptoms were positive. Of those coming forward with symptoms, 112,000, 71.6% were negative. So again, we can see we've got two groups here. We've got basically the experimental group here, and we've got a control group of people who tested negative. So we've got two large data sets to compare and contrast. Now, the interventions were 1 or 2 doses of the Pfizer vaccine. A few people got a second dose of the Pfizer vaccine before the policy change. Well, when I say a few, I think it was about 500,000 actually. But so it's quite a few got. I think it's about over 500,000 now have had the second dose of the Pfizer. So it's not small numbers. But anyway, so they had 1 or 2 doses of the Pfizer and only 1 dose of the Oxford Astrazeneca vaccine, because by that time the Oxford Astrazeneca vaccine was approved and instigated and rolling out. We'd already changed to the one-shot policy to try and cover more people more quickly. Right, main outcomes. What they look for was symptomatic PCR confirmed SARS-CoV-2 infection. In other words, to be confirmed positive, these people had symptoms and a positive test. So these were symptomatic positives that the study was looking at. And they also looked at hospitalisations and deaths with COVID-19. We know that's massively important. Right, symptomatic disease infection risk. So this is the likelihood not of getting infected. It wasn't testing for that. It was testing for the likelihood of becoming symptomatic and testing positive, because these were people that came forward for community tests due to concerns because of the symptoms that they had. But that generated this nice, large, statistically valid data set. Right, so symptomatic people, first of all, over the age of 80, vaccinated with the Pfizer. Now, higher odds of testing positive in the first 9 days after vaccination. In other words, for the first 9 days after vaccination, there were 48% more likely than people that were not vaccinated to test positive. So it looks like the vaccination's having a 48% bad effect in those first first 9 days. Consistent with the Israeli data, if you remember, where they tested several million people as well. Now, 2 reasons for this really. One is that the people that were vaccinated first were considered to be at highest risk of infection, such as people in hospital, for example, or in care facilities who are at higher risk of infection. So that's one reason. And also, I think we have to consider the possibility that in these earlier days, people changed their behaviour and behaviour became more risky. So we know now that this vaccine's taking time to kick in. So the first 9 days increase in risk of infection. But then vaccine beneficial effects, remember this is with a Pfizer in this particular example, vaccines affected were noted from day 10 to 13, so some beneficial effects started kicking in, reaching effectiveness of 70%, but it took 28 to 34 days, 4 or 5 weeks. Now this really has to be drummed in. We're not getting the full beneficial effect of 4 or 5 weeks after the first dose of the vaccine. And of course, most of these people were only given 1 dose. But the ones that were given 2 doses from 14 days after the second dose, that efficacy went up to 89%. So no question that 2 doses there is increasing the efficacy. What we still don't know definitively really is the optimum amount of time between the 2 Pfizer doses. It's looking like the 3 months is going to be absolutely fine, but we don't know that firmly yet. At least I haven't worked that out yet from the data I've read. But this is from different data. But now there's fewer than 10 over 80s sent to the intensive care unit every day in all of the UK, as far as I know, so it'd be even less in England. So basically, the number of over 80s getting sent to intensive care now is dramatically reduced. And we will see this throughout the age ranges as well. I'm very, very confident we'll see this throughout the age ranges as the vaccination programme extends. So it would be amazing if we didn't. I'm sure we will. I'm sure we will. Now, individuals aged greater than or equal to 70, again with the Pfizer vaccine effectiveness reached 61%. So less in the over 70s. What is going on here? So it was 70 in the 80s or over, 61 in the 70s or over. Now, I assume this is partly behavioural and partly because these people were at lower risk anyway. So I think it's that the people in that bracket who were vaccinated later were at lower intrinsic risk of getting the disease. These figures probably will change with time. I'm not saying that's a full explanation. It's not. I am still partly puzzled by that. So more information to come on that, I suspect. To be fair, if we knew everything straight away, it would be a bit boring. This is kind of why this is interesting. I was kind of on tenterhooks waiting for this information, and especially this bit. The Oxford chimpanzee adenovirus, Oxford AstraZeneca vaccine, effects were seen from 14 to 20 days, so similar, slightly longer than the Pfizer to get. So the Pfizer was 10 to 13 days, some effects were seen. This is 14 to 20 days. So again, patience is required after vaccination. The effects are not instant. And we looked at this recently, the memory B cells, the T cells, the sensitization of the natural killer cells, all takes time, and it takes longer than it does to produce antibodies, to produce this multi-pronged but quite brilliant immunological response that the body's capable of mounting. Anyway, the Oxford AstraZeneca vaccine reached 60% efficacy. This is in preventing symptomatic disease, remember, after 28 to 34 days. So the figures there, Pfizer over 80 is 70%, Pfizer over 70 is 61%, and the whole group for the Oxford AstraZeneca vaccine 60%. So we can see that the Oxford vaccine, okay, it's 60%, 61%, but it's basically the same. But, and this is a big but, and it's a good one. It's quite fascinating. Oxford AstraZeneca vaccine protection against symptomatic disease, which tested positive for SARS coronavirus 2, increased to 73% after 35 days and onwards. So interesting. So 28 to 34 days, 60%, about the same as the Pfizer. But then the Oxford AstraZeneca vaccine, in terms of protecting against symptomatic disease, overtakes the Pfizer and becomes more efficacious at 73%. So there you go, 35 days, a month and a bit to reach full protection, but good levels of protection against symptomatic disease. Now, it gets better. Risk of emergent hospitalisation and death after one dose of the Pfizer vaccine, it was an additional 43%. Now, it's an additional 43%. Now, obviously, the people, well, it's not obvious, it took me a while to think about it, but the people that didn't become symptomatic and didn't test positive, they would not go on to be hospitalised with COVID-19, obviously, because they don't have the infection. So this is an additional benefit to preventing symptomatic disease. 51% lower of death. So we add those together. We'll see what the result is in a minute. 1 dose of the Oxford Astrazeneca vaccine, additional 37% lower risk of emergency hospitalisation. Now, disappointingly, insufficient evidence as of the close of this study, which was, what did we say it was? 19th of February. So as of the 19th of February, insufficient evidence to calculate the reduced risk of death from the Oxford AstraZeneca vaccine, but given that it was lowering the risk of hospitalisation in addition to preventing symptomatic disease, we can assume that it's good. Combined effect against symptomatic disease, right. Single dose of either vaccine is approximately 80% effective at preventing hospitalisations. So there we are. Combined effect against symptomatic disease, and we could include hospitalisations there. Should have probably put that in. 80%. 80% protection against hospitalisations. And note, this is after a single dose. After a single dose, 80% protection against hospitalisations. Single dose of the Pfizer vaccine is 85% effective at preventing death. 85% less likely to die. And this is just after a single dose. So these are remarkably good figures. So for both vaccines, it comes out at 80% protection against hospitalisation. And as we said, that's even looking better now, because we know in the UK as a whole, only 10 people over the age of 80, who of course are the most immunised group now because it's had longest to kick in. We know that only 10 of those a day are being admitted to intensive care, whereas I don't know how many there was before, many hundreds I would imagine. Well, it would be many hundreds. So dramatic reduction. So single dose of either vaccine, 80% preventing hospitalisation. Single dose of the Pfizer vaccine prevents deaths by 85%. I would expect the Oxford data to be similar, but we simply don't know because we haven't had the time yet. But I would expect it to be similar. So at the moment, we don't know. My guess would be about the same. Given that they're both 80% protective against hospitalisations, they're both the same at that, you would expect the protection against deaths to be the same because it's the most poorly people that get admitted to hospital. But we can only speak as far as the evidence goes. And that's as far as the evidence goes. More will be out, I would imagine, next week or the week after. Conclusions. Significant reduction in symptomatic SARS coronavirus 2 positive cases in older adults. Tick. Definitely. Greater protection against severe disease. So good protection against symptomatic disease, but even better protection against getting very sick. Even better protection against hospital. And in the case of the Pfizer vaccine, even better protection against deaths. Both vaccines show similar effects, as we know, but just that we haven't got the death data for the Oxford vaccine yet, but we believe it's going to be similar. Protection was maintained for more than 6 weeks. Now this is an absolutely vital point. The longevity of the immune response is not known. Now we know in Israel, well, it's hard to tell in Israel, but we've got good levels of immunity now, 10 and 11 weeks after 2 doses of the Pfizer vaccine. We don't know what the levels of immunity are from the Israeli data, 10 or 11 weeks after a single dose of the Pfizer vaccine, because they've given virtually everyone 2 doses now. And the people that have had the first dose are coming back for the second dose, so we don't know that. But we've got good data, 10 or 11 weeks now from Israeli data, and here we've got for more than 6 weeks. Now, the immunity is not going to go good 6 weeks, good 7 weeks, good 8 weeks, good 9 weeks, good 10 weeks, then drop off a cliff. If it's going to wane, it's going to wane gradually, but so far it's looking good. Now, how long does the immunity against SARS coronavirus 1 last? Well, the answer is so far 18 years, because it's been 18 years since the first cases. So we have to wait for the time to elapse. We simply don't know yet. So it's looking good for longevity of response at the moment. Second dose of Pfizer provides further protection against symptomatic disease. Good. So as people start getting vaccinated after the 3-month gap, that as we'll be starting pretty soon now, actually. We're starting pretty soon now. Protection is going to increase. Second dose of Oxford vaccines have not yet been rolled out in England, so we don't know the data for second vaccines. But of course, we would expect it to be enhanced after the 3-month gap. We would expect that. It's bound to happen, really. Well, it is bound to happen. But does it happen or not? Well, we don't know because we haven't done it yet. It would be amazing if it didn't. It will. But in absolute scientific terms, we don't know because we haven't done it yet. There is clear effect of the vaccine against the UK variant of concern because, as we noted, most of the people that tested positive in this study did test positive for the new B117 variant of concern. And the B117 variant of concern, by the end of March, should be the most prevalent form of the infection in the United States. So this vaccine information is vital to the United States, and it means they need to carry on doing what they're doing, only more so. Of course, in the UK, we're not yet giving out the Moderna. Our supplies of Moderna should be arriving in March, sometime we hope. But obviously, this data says nothing about that because we haven't done it yet. Professor Jonathan Van Tam, I think he's Deputy Chief Medical Officer. Seems a pretty switched on bloke, actually. He said the Joint Committee on Vaccinations and Immunisations thought it was not immunologically plausible the vaccine would work in younger age groups and not the older ones. This is why we gave it out to older age groups straight away, and boy was that the right decision. Now, when he says not immunologically plausible, I agree, but to be fair, on the Pfizer vaccine, for example, we had very good phase 2 clinical trial studies indicating efficacy in older people. But what Professor Van Tam here is saying, that if you just apply the basic science of immunology, it would be incredibly unlikely that you would get such a good response in younger people, and all of a sudden, at 65 click, that the response stops. I mean, it's not as simple as that, of course. There could be a gradual reduction in response. But what he's saying is, from immunology that we already knew, from science we already knew, this should have been workable, outable. People should have been able to work this out. I mean, in France, they've got some of the best immunologists in Europe, in the world, at Pasteur Institute. They must have known this is just basic degree level immunology. They must have known this. Why didn't the message get through to President Macron, who was saying this is quasi-ineffective at one stage? Now, the reluctance to take up this vaccine in Europe, as we'll see, has been a problem. So I think the manly thing to do would be for President Macron to stand up, or the Frenchly thing to do, or the right thing to do would be to stand up and say, look, sorry, I said it was quasi-ineffective, take it back, got it wrong, my mistake. It's good, let's move on. If he did that, that would massively improve confidence of this vaccine, the Oxford vaccine, in Europe. If I make a mistake, if I become aware of it, I'll come on the next day and I'll say, sorry, made a mistake. If he did that, that could save lives. Whether that's politically possible for him to do that or not, I don't know. But it would be the humane thing to do, I would have thought. More on that in a second, or the European situation anyway. Dr. Mary Ramsey, Public Health England head of immunisation, said it could. Said if anything, we would expect it to be a stronger protective effect in younger people. So we don't know about younger people yet, but she said she's expecting it to be an even stronger effect. Lower down the age ranges, that people's chances of being hospitalised and dying are much lower. So although we won't see the great reduction in numbers that we're seeing in the older people, the percentage of reduced hospitalisations, the percentage of reduced symptomatic disease, the percentage of deaths for a particular age band should be reduced equally, although the numbers will be less. But the percentages, I would expect to be the same. I hope I'm not putting words in this doctor's mouth, but I think that's basically what she's saying. So the numbers aren't going to be as impressive, but the percentages should be the same. Now, France has backpedalled slightly. The Oxford Astrazeneca vaccine to be given to people between the ages of 65 and 74 if they have an underlying health condition. Well, I would appeal for them to immediately give it to everyone who wants to accept it between the ages of 60 and 74, even if they're bouncing fit and still running marathons, even if they have no underlying health conditions. So we'll give them a half a mark for that. They could do better. They're not getting a tick for that because it's only people with underlying health conditions. Now, 1.1 million doses in the country. Let's hope they get bashed out ASAP. Germany still not giving the vaccine to over 65s. Come on, Germany. The land of logic, reason, the land of learning, the land of Robert Koch. Come on. It's now under discussion. Good. Large stocks of the vaccine waiting to be used. I don't know. I think there's a couple of million doses in Germany sitting there. Belgium need to get their act together. Poland need to get their act together. Italy need to get their act together. And Sweden need to get their act together on this. Because at the moment they are being... I nearly used the term ageist then. They are not giving the vaccine to the older age groups, and that needs to change because now we have the evidence. Follow it. Professor Andrew Pollard, head of the Oxford Vaccine Group. I don't know if he's a sir yet, but I'm sure there'll be lots of people honoured in the honours list for these amazing work that these people have done. Findings are stunning, direct quote. If he's stunned, I'm stunned. About 5,000 people are dying every day in Europe, and it's important to increase confidence in vaccines. Mr. Macron's apology would be a good start for that. Now, Professor Pollard is much more polite than I am. I've said the Europeans got it wrong, not giving the vaccine to the older age group. He's been much less forthright than that, much politer than me. He said it's disappointing in some senses. Now, this is, if you're watching in the States, this is polite British understatement. Disappointing in some senses means it's been a crushing tragedy for many people, I would have thought, in my view. For the ones that have died, for the families that have suffered losses and bereavement. Because the vaccine offers really high levels of protection, supporting their decision making. Now, what he means is that these countries that need to review their policies, this data will support their decision making. Again, a remarkably polite way to put it. And of course, what we need is an official declaration this afternoon. Would be nice from the European Medicines Agency to clarify this all over the 27 member states of the European Union. People are dying on a daily basis. This could not be more important. And Professor Pollard also notes with some satisfaction, I believe, Oxford vaccine in the next few days being distributed to low-income countries under the COVAX scheme. So there you go. Very good news. High levels of efficacy against preventing symptomatic disease, even higher levels of efficacy against preventing hospitalisations, even higher levels of efficacy against preventing death, at least with the Pfizer vaccine, and data to confirm the same in the Oxford vaccine within the week or two, I would think. That's us for today. Now, just one thing that's been irritating me, and this is unpleasant, but we have to talk about it. I've had a bit of trouble with cloned sites. Now, if you see me in the comments, okay, so we've got a little picture there and me. Now that tick there is not clonable. That tick. So if you see John Campbell and no tick, it's not me. It's not me. If it's me, it'll have that tick. So remember that, no tick, no me. Now I've banned the person that was impersonating me from the channel. They were doing it for commercial purposes. I will never use the channel for commercial purposes. That's not quite true. I did use it to push my books or advertise my books a couple of times, but that's all part of this project. But other than that, this is not commercial anyway. And people in the comments seeking to use it for their own commercial ends, utterly outrageous, of course. But that is how you tell If it hasn't got that tick, so if all that bit looks perfect, the picture and all that bit looks perfect, but there's no tick, it is an imposter. Just report it to YouTube as spam. Okay, so what an uplifting day. The vaccine programme is looking good, and not only that, I think I'll go and do some digging at my allotment now, because it's sunny. Now, I live in the north of England, so it's too early to make any vitamin D, basically at all, hardly. Well, no, I don't think you make any at all from the sun. But it stimulates the pineal gland, and you produce some melatonin, and you feel a bit better. So that is good. So I'll go and do that now. And thank you for watching. As always, it's good to communicate, and when it's good news like today, it's so much better, isn't it? We are going to. I'm not going to say we're going to vaccinate our way out of this pandemic, but boy, is it going to help.